Why is EuroPCR unique to me?
What makes the EuroPCR very unique for me?
Because it's an ideal place to develop some networking and to develop my career.
Because it's by the community, for the community.
It was driven by innovation in science and education.
It offers a worldwide scope with colleagues from all over the world.
It's the warmth with which we're welcomed here at EuroPCR. It's the emphasis which EuroPCR puts upon education, education, education.
Coronary interventions, valvular disease, interventions for stroke, interventions for hypertension, peripheral interventions. Whatever you're interested in, it's right here.
And now,
It's the time to enjoy the highlights
of EuroPCR 2017.
Welcome. My name is Jonathan Byrne. I'm a cardiologist from the UK. I'm joined by my colleague, Dr. Tom Johnson, a colleague from Bristol. We're here to discuss some of the highlights of the meeting this year with a particular focus on the coronary information and data presented here. It's been a fantastic meeting looking back at 40 years of angioplasty, a real sense of history, and great to see that the education is firmly embedded in the programme with the European Fellows course integral to the meeting this year. We're going to discuss some of the major discussion points of the meeting this year. I'm going to move over to Tom and ask him really to talk first about the evolving and interesting data in the bioresorbable scaffold arena. Tom.
John, thanks. There's been a lot discussed about BVS again this year, with particular emphasis on, again, ongoing data being drawn from global registries, from the Absorb Japan, Absorb China data. We also heard some new data from the IDA investigators from Amsterdam. And certainly we see with the first generation devices still this ongoing signal in terms of stent thrombosis. Clearly there was a very high stent thrombosis rate associated with the IDA investigators, 4% over the period. And in fact the trial was stopped early. They admitted in the discussion actually that that was stopped as a result of the 3-year Absorb 2 data that was published last year. Having said that, there's some conflicting and contrasting kind of messages that come from the registries. So the UK registry was presented for the first time by Andreas Baumbach, and that showed again this stent thrombosis issue, but to a far lesser extent, just 1.4% across the 12 months that we've investigated. And there it seemed clearer that, again, small vessel, under expansion, poor preparation was potentially the driver. So, I think there's still lots to learn in terms of the first generation BVS.
And there's some interesting data from the second generation bioresorbable scaffolds. I think it's fair to say that it'd be worth talking a little bit about that evolving data, because that may deal with some of the weaknesses of the first generation devices.
I think clearly the technology is evolving, and we had some data on the Magmaris from Michael Howday. So we had the 2-year Biosolve data, and that is a different device, obviously magnesium, and we saw a 0% stent thrombosis rate. So there are new technologies evolving. There have been additional plenary sessions looking at the many devices that we may have on offer in the future. So I think it's still a space to be excited by.
Agree. I think it's fair to say that will evolve significantly in the coming 12 to 24 months. And if we move to more complex intervention, particularly chronic total occlusions, there's been interesting data presented here on that aspect of coronary intervention as well, hasn't there?
Some reassuring data, I guess. So, off the back of Decision CTO, there were maybe some concerns about whether we see an advantage with the reopening of CTO in the stable setting. And so Gerald Werner presented for the first time the EuroCTO data and highlighted the primary endpoint being one of quality of life questionnaire, looking at reduction of angina, looking at symptom relief, and we saw an advantage clearly through the reopening of the CTO versus optimal medical therapy. Now, there was a clear distinction really between now the two trials that we have with conflicting results. The EuroCTO investigators should be commended on having assessed viability, having made a formal assessment of those patients before including them in the trial. There's still a lot more data that we haven't had at our disposal to pick through to understand the true detail of the study, but it's an encouraging result all the same.
I think it's been interesting to delve into the data as more of it emerges. I think we'll learn a lot more from it. And finally, if we move from intervention to physiology and intervention, there's been very interesting discussions here on the IFR, FFR argument, and perhaps some alignment in thinking and how these should be used. Perhaps you could enlighten us on
absolutely.
On that
so
data.
Obviously we now have a very large body of evidence assessing head-to-head IFR and FFR, and so this week Javier Escanay presented the pooled data from IFR Sweetheart and Define Flare over 4,000 patients and highlighted really that both FFR and IFR are achieving very, very effective results in terms of deferral and treatment strategies. There's some interesting data again to kind of tease out from that in terms of the fact that we now have a much larger body of evidence within the ACS cohort, and so we maybe see a slight difference in the way that IFR and FFR guide us in terms of revascularization strategy. So we saw a difference in the outcomes between ACS and the stable setting for FFR, and actually no significance between the IFR groups. But I think probably the greatest message is that over this period of 20 years almost from DEFER, the first study that defined the importance of physiological assessment, we see a halving almost of the overall event rates driven by this physiological approach to our guided angioplasty. And so, we see a very nice kind of evolution of innovation, very much in keeping with this special edition PCR of 40 years of angioplasty.
And it's a very nice message to end on, 40 years of progression development with new tools, new innovative devices which help us to really obtain the best outcomes for all of our patients. Thank you very much, Tom.
Hi, my name is Niccolo Piazza. I'm an interventional cardiologist from Montreal, and I'm joined here today by Bernard Prendergast from London and Azim Latib from Milan, both interventional cardiologists. Welcome.
Thank you.
So maybe Azim, you can start off by telling us what were some of the highlights from PCR with respect to the aortic valve space.
So probably, Nico, the part that struck me the most was Reprise 3. Okay, so for those who don't know, this is the first industry-sponsored randomized controlled trial comparing two different valves. So it compared the Lotus valve versus core valve, randomized 2-to-1, and they presented for the first time the primary endpoint of the study. And so what it showed, really, if I could just generalize, was similar safety endpoints. So as regards to at 1 year composite endpoints, similar for both valves. I think what we'd expect, less PVL with Lotus, significantly less moderate to severe PVL, but higher pacemaker rates.
Okay.
But overall, I think an important study to know about.
And how would this impact your clinical practice?
Well, I think what this will do, in Europe we did have Lotus commercially available, and I'm sure it will come back. I'm sure this study will allow it to be approved by the FDA in the near future. And I think it helps us in our selection of valve choice for patients. If I need a valve in a patient with a lot of calcification and I want to get rid of PVL and I don't want any PVL, this confirms Lotus could be that valve.
Bernard, yourself, anything interesting in the aortic space?
Well, the updated ACC guidelines early this year for intermediate risk patients undergoing TAVI was a major step forward for the technology. But one of the concerns as we go into low-risk cohorts has been the issue of valve durability. And as you know, that's been quite a hot area of controversy over the last 18 months or so. So it was very reassuring for me to see the 4-year results of Notion presented at this conference by Lars Sondergaard and his team. And the take-home messages from this study are that the valve performance at 4 years supersedes that of surgical prostheses with a higher effective orifice area, lower valve gradient with equivalent clinical outcomes. So very reassuring in a randomized control trial setting with multiple TAVI devices, indicating that the durability story is sustained out to 4 years at least. And this clearly is very encouraging as we move into lower and lower risk cohorts.
Excellent. So we've talked about the aortic. Azim, let's move over to the mitral. What have we heard here at PCR about transcatheter mitral valve repair or replacement?
Right. So, you know, for most of us, we're all looking at the mitral space. It's a really exciting space. And I think the thing that struck me the most here was the presentation for the first time of the Edwards Pascal data. So Pascal is a new device for mitral valve repair that does edge-to-edge, okay? Besides bringing the leaflets together, it also acts as a spacer and has some advantages over other edge-to-edge devices because you can independently grasp the leaflets, which I think could be really useful. So we saw the data from the first 23 compassionate use patients, which showed that, you know, the device was implanted successfully in all patients with good results, reduction in MR, no real complications. So it's just, I think it's exciting because we realize we're going to have a larger toolbox with really good effective devices to repair the mitral valve.
Okay, so another alternative emerging device for an edge-to-edge type of mitral valve repair.
Right, absolutely.
And Bernard, there was something about transcatheter aortic valves, but in the mitral position for mitral annular calcification.
That's right. So the MAC cohort and a large registry presented this week demonstrating that the procedure is feasible via either transapical or transeptal access. So two different approaches to the implantation of the valve. Results on echocardiographic and clinical follow-up demonstrating that the valves function very well in the mitral position. The clinical complications are not insignificant, and I think that has two important messages for the clinical community. One is that we need to be very careful with patient selection. We need to be careful to avoid intervening on patients where an intervention is futile, so avoiding the excessive risk category, and also refining the techniques and ironing out some of the procedural steps to ensure that we reduce the procedural complications. But certainly feasible and a very exciting area to watch.
Very good. And Azim, maybe we can finish off with the tricuspid space. Yeah. What do you think about the tricuspid space and what have we seen here at PCR?
Sure. So I think it's going to be a very exciting space. You know, we've seen during this week an array of devices from Innovation Day, and then during every day there's been some device shown either as a clinical case or some data. I think what we're seeing is an array of repair devices for the tricuspid, a valve also arriving, and I think it's going to be an exciting time because in Europe right now we have probably in the next few months there'll be 3 ongoing trials in the tricuspid space. So one for the Edwards Cardioband, the tri-repair study. There's the SCOUT-2 study for the tri-line device, and then also the Triluminate study for the tricuspid clip. So very exciting times. But what do you think about tricuspid space, Nico?
It is definitely something emerging and evolving, and we have a certain number of devices out there, and you know, we're just at the beginning. So the results are encouraging, as we usually say, and I do think there's an unmet need in this space, and I think transcatheter valve interventions within the tricuspid valve are going to meet these needs. So I think we've heard that the field of transcatheter valves is very dynamic. We've heard about new devices and new registries and trials going on. I think this is a good indicator of how healthy the field is, and that we are eventually going to be treating our patients more and more with transcatheter valve interventions. Thank you.
Thank you.
Hello, everyone. My name is Marco Roffi from Geneva. I'm in interventional cardiology, and I'm happy to welcome you to this PCR TV session on highlights at EuroPCR on stroke. And it's my great pleasure to have 2 experts in the field and friends with me today. We have Nick Hopkins from the US, neurosurgeon, and we have Omar Götkekin from Turkey, interventional cardiologist. So first of all, let me start with you, Omar. So what was hot? What were the highlights on stroke at this meeting?
So in this meeting we had several very successful sessions again this year, and what's good enough for us, the whole sessions were full, and cardiologists has big interest to acute stroke intervention, which is very, very grateful for us. If you say why all the cardiologists interested in acute stroke, I could say because we have very compact data to support endovascular treatment in the acute stroke intervention. In 2015, we have 5 big trials. All of them showed benefit of endarterectomy comparing to thrombolysis. And after that, for example, in those cases, number needed to treat was between 2.5 to 7, which is a great number for us. And also we should think that there is still room to be improved the technique, because in those studies, recanalization rate is not so high. It was about 65%, 70%. So there are still room to improve our techniques to treat more patients successfully. In this year, we had great sessions. We discussed all techniques again, and we discussed latest data. And I think Nick will talk about the new data just published 2 days ago. And all these things makes us more keen to interest acute stroke intervention.
Yeah, this is a great news. So Nick, tell us about this new trial. This was heavily discussed here at PCR, and apparently very promising.
Sure, thanks Marco. We've had multiple trials over the last 2 years that showed overwhelming benefit for intervention in stroke. But they were all out to 6 hours only. And the DAWN trial results were just released this week. And that is a trial that compared IVTPA to IVTPA plus clot retrieval with the Trevo device from Stryker. And that trial this week was stopped early because of overwhelming benefit for stroke intervention out to 24 hours, which is an extraordinary change for us.
New paradigm.
It's a whole new paradigm. Now it does require, patient selection, so we have to be careful about who we pick, but the results are exceedingly good. The bottom line message here for us is that there are 16 million strokes in the world every year. Somewhere between 30 and 40% of those patients with strokes are amenable to intervention. We need an army of interventionalists in order to treat these patients with acute stroke. And the only place that I can see where this army can come from is interventional cardiology. So we need cardiologists to become interested, to be willing to spend some time training, and to get into the stroke business as soon as possible. It's really critically important. We have the most overwhelming data in support of intervention of anything I've ever seen in medicine. And I can only tell you that there's nothing in my career that compares to what you see in a patient who comes in unable to speak, paralyzed on one side, completely out of it, 1 minute. And when the clot comes out, within minutes, that patient is moving, talking, and then an hour later, up reading the newspaper. It is an extraordinary change that you see in these patients when you can remove the clot early and get reperfusion of the brain. So it's an exciting time, and cardiology is absolutely essential for us to be successful worldwide in the treatment of stroke. We just don't have enough neurointerventionalists around the world.
I mean, Nick, I hear your enthusiasm, and you're talking to somebody who really believes in it. So I think the message is clear for everybody. Stroke, interventional treatment of stroke is the future. And in this future, for the wealth of our patient and for the good of our patient, we need interventional cardiologists on board. Having said that, I would like to thank our guest, my guest and friends, and welcoming you to the next session of EuroPCR Highlights.
Welcome, my name is Sebastian Even from Hamburg, Germany, and I'm happy to be here at the PCR TV booth together with Felix Mahfoud, also from Hamburg, Germany, and Atul Pathak from Toulouse, France. We are here to give you an overview about the highlights in hypertension track, and I would like to start with you, Atul. What was your highlight this year?
Well, I was very excited by a session trying to share new devices in the field of hypertension, which are aiming the carotid area. And there were two very interesting discussions about something some of us know, which is baroreflex activation therapy, showing that by the means of a device which is stimulating some sympathetic fibers, we are able to reduce blood pressure. There are trials on the way, some disappointing data, but also some new data is coming on, and maybe also hope for hypertensive patients with heart failure. And another device, which is a kind of stent, again aiming the same area, which will be put into the carotid artery, reshaping basically this area where there are these stretch receptors, and by this playing again with the baroreceptors, reducing blood pressure, and there are again trials on their way. We are very excited and waiting for data with these new devices.
Thank you too. Felix, what would you like to add? What was your highlight?
There was a very interesting discussion about a new device, the transcatheter approach to treat, to modulate a small rice grain-sized organ, which is the carotid body. It is located just at the bifurcation of the carotid body. You enter a device that comes with an IVUS console. You can visualize the carotid bifurcation. You have an ultrasound transducer included in that device, and by locating the carotid body, locating the carotid bifurcation, you then emit energy to that area of interest, and thereby you modulate this small organ that has formerly been surgically removed. By doing so, you can reduce sympathetic activity. There are first-in-man trials ongoing in hypertension. Some are planned in heart failure, and this is truly an exciting new approach.
But will you also give us an overview about renal denervation in 2017?
Of course, the trials are ongoing. We have 4 randomized sham-controlled studies. They are investigating 2 different subsets of patients, one being those who are not taking any antihypertensive drugs or drug-naive patients. Those patients will receive either denervation or a sham treatment. Outcome is always ambulatory blood pressure. We have an on-medication group where patients are on a standardized antihypertensive drug regimen. Outcome here is also ambulatory blood pressure compared between denervating and sham treatment. The results are expected to be presented hopefully end of this year, beginning of next year, and it will for sure be an exciting year for renal denervation.
And from a scientific standpoint, what would you like to add at all?
Well, I think we had the chance while we were at this meeting at PCR. There was the release online on the site of the European Heart Journal of a very nice paper, which is basically the 2nd edition of proceedings putting together all experts in the field of hypertension and device-related therapy, called a clinical conference. It was a kind of clinical conference consensus paper, which is finally wrapping up what we have been through and giving some indication not only about where we stand, how we should move forward, and also playing with the potential results of trials. So I think it will be very interesting for our audience to go through this paper, which is nicely wrapping up all highlights regarding device-based therapy in the field of hypertension.
Thank you very much, Atul. So as you could hear, we have a lot of interesting new tools available for interventions in hypertension, and we're really looking forward to discuss next year at PCR 2018 the new results of the renal denervation trials. So we are looking forward to see you here in Paris. Thank you very much.
Thank you.
Hello everyone, we are here in the last day of EuroPCR 2017. With me is Marco Roffi, who needs no further introduction. I'm Piotr Muslek from Kraków, Poland. With Marco, we are to discuss the highlights of this year's EuroPCR in peripheral interventions. But Marco, why are we, 2 cardiologists, supposed to talk about peripherals? What's the reason?
Yeah, Piotr, I mean, there are multiple reasons. Number 1, atherosclerosis is the same disease in the coronary artery or in other districts. The principle of endovascular procedure are similar, although the target organs are different, and obviously we need specific knowledge and skills. And third, the peripheral management is becoming more and more important because the interventional cardiologists are handling now large bore catheters in the femoral artery. So they need to know how to handle complications, for example, for TAVR.
So that's why we have seen this year so many people in sessions, such as complex aorto-iliac endovascular repair.
Indeed, there is a lot of interest, and we had a lot of sessions that were full of people, and more and more people are getting interested in peripheral interventions. I would say that there were a lot of highlights.
But Marco, what are the most important things? What has struck you most this year? What are the new things?
Yeah, I mean, there were several highlights. First of all, I would like to say that the common femoral is no more a unique target of the surgeon. So today, for selected patients, we have very good option to treat in an endovascular way the common femoral artery. Number two, drug-eluting balloons are now established in the treatment of superficial femoral artery, and we have several studies in this year PCR that have underscored the role. While we have to say that for below the knee, the role of drug-eluting balloon still remains to be determined.
So further research to be done.
Clearly. And then obviously now we can reconstruct the aortic abdominal aneurysm with very low profile device, 14 to 16 French device. So many and more people will be confident now that they are used to use this large bore device for TAVR to embrace also endovascular repair of the aorta. And finally, we have also very good data and very promising data on the stenting, carotid artery stenting side.
So not only down from the heart, but also up to the brain.
Up,
so
clearly.
what's important on the way to the brain?
So on the way to the brain, obviously we want to reduce distal embolization. And we have done a lot in this latest years. First of all, with emboli protection devices. The first generation was distal protection with filters. Now we have proximal protection, much more effective. And already last year and this year, very hot, the double layer mesh stent that really should prevent any distal embolization at the time of the procedure.
And also we know that with the prior generation of stents, a lot of events happened after the procedure.
Exactly.
Now with the new generation, with the micronet or mesh protection, are we effective in really preventing this delayed embolization of carotid stenting? Are we going to be as good as endarterectomy or maybe even better?
So this still remains to be defined, but the first experience are very promising. And here we have seen a lot of cases with control of IVUS, and really there is no more plaque protrusion, and even centers that do a lot of this procedure, they really do not see plaque protrusion anymore. So this clearly major advantage.
Another border crossed, another enemy defeated, yes?
No, not yet defeated. Don't say it too loud. So obviously we will need adequately powered trials. But these data are promising, very promising.
Okay, so thank you very much.
My
thank
pleasure.
you for the excitement. And as the last word, I would like to say, please come and see us at PCR Peripheral. This is Milan, mid-October. Yeah? Another growing course, yes. PCR Peripheral.
We'll be there.
We'll be there. Thank you.
Thank you.
Hello, Nina. You are the hero of the day, of the EuroPCR final day 2017. Can you introduce you?
Well, thank you for the nice introduction. I'm Nina van der Hoeven. I'm from the VU University Medical Center in Amsterdam, and I'm a PhD fellow.
Nina is the hero because she had the award of the best abstract, which is a Veritas process. Can you explain us a little bit what we went through to get there?
Yes, of course. Thank you. Well, on Wednesday we had to present our research in the first round, which was 3 minutes without slides. And then the next day, if you went through, you had to present your work in 5 minutes with slides. And then today was the last round, and we had to present our research in 8 minutes, and there were 5 minutes for questions. And the winner had to present his or her work in the main arena.
Congratulations.
Thank you very much.
That's a wonderful achievement. And what your research was about?
Well, what we did is we developed a new method to separately assess the amount of epicardial and microvascular disease using one method which describes the whole coronary vessel.
Congratulations. It was nice research, and also many other difficulties that are to present without slide and so on. Can you give some tips to help the people of next year, the young doctor that will want to have this award next year?
Yes, of course. My main tip would be to keep it very, very simple. There are a lot of people who do not know a lot about your research, so I would say keep it simple. For instance, I used a metaphor with apples and pears, so I would keep it simple and use metaphors. That's my tip for next year.
Thank you so much, Nina. And again, congratulations. We are extremely proud of your success.
Thank you very much.
This year was the 40th anniversary of angioplasty, and we celebrate that. So happy anniversary to all of you.